Good afternoon. I am Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to our weekly update on innovations and program developments in the Department of Surgery. Today's topic is solid organ liver transplantation, and I'm thrilled to have Dr. Johnny Hong, Chief of our Division of Transplantation, joining me today. Johnny did his surgery training at the University of Texas in Houston, where actually we first met. He then completed his fellowship in organ transplantation at UCLA, and they were smart enough to not let him go anywhere, and he stayed on staff there for many years before we were thrilled to be able to recruit him here as the inaugural holder of the Mark Adams Chair in Surgery and Chief of our Division of Transplantation in 2012. So Johnny, welcome. Thanks for spending a little bit of time with us this afternoon. And maybe we can start in the field of liver transplantation by talking a little bit about why in some patients the liver doesn't work. Why would the liver fail, and would it need to be replaced?
Yeah, so there are different diseases that could end up in what we call end-stage liver disease, wherein while the liver can regenerate and regrow, there will be a point where the scarring is too bad, it's not able to regrow, and the only way to save their lives is to replace it. Now, compared to other organ failure, such as heart failure, lung failure, kidney failure, liver failure, patients do not have the option of survival because there's no such device to keep them going as a bridge while waiting for an organ transplant. For example, for kidney failure patient, they have the dialysis machine. For heart failure, they have the fancy pump that we have now. Lung failure, we have the ventilator. But for liver, because of its complex function, there's no device available to bridge them over.
Huh. And what causes the liver to fail? What are the most common causes of liver failure that may affect the patients that you see?
Yeah. So for children, it's the congenital biliary atresia, still number one indication for liver transplant. Now,
so they're basically born with this then?
That's correct, yeah. And then for adult, it's different. The most common used to be alcoholic cirrhosis. Now, over the past 15 years, it has been hepatitis C. Now, with advance in hepatitis C treatment, we're looking and anticipating that non-fatty liver disease will be the number one reason for the need for transplant in about 5 to 10 years.
Huh. So initially the main indication was probably alcohol-related liver cirrhosis, and then hepatitis. Yeah. As you mentioned, the treatments have become incredibly good for hepatitis. And now, can you expand a little bit upon fatty liver disease? I mean, I assume that this is exactly what it sounds, that due to the fact that the population at large is getting bigger, obesity is becoming more and more of a problem. Does that itself cause liver disease?
So it does, but although the name said fatty liver disease, can be confusing because the patient may not be really fat to have this. It's more of a systemic autoimmune reaction, wherein it's a non-alcoholic related inflammation of your liver, converting it into a fatty liver. That with the chronic inflammation leads to cirrhosis and then end-stage liver disease.
So it really has nothing to do with the size of the patient?
No.
Fascinating. And it got its name just from the histology, in other words, what it looks like under the microscope.
That's correct, yeah.
Yeah. And so when patients, does a patient know that their liver is starting to become a problem? So
the most common symptoms would be just loss of appetite, in one generalized weakness, just not feeling good. So it's very, very nonspecific. And then oftentimes it's the family member that would notice them, as the function of the liver deteriorates, they start to accumulate fluid, that their abdomen gets bigger, what we call ascites. Yeah. And then the last would be is when people notice that the eyes are yellow, what we call jaundice. And typically it's very, very nonspecific. So it is very important that they get checked oftenly by a physician to make sure that their liver function remains normal.
So is it safe to say that you as a transplant surgeon, most of your, and as someone who runs a big program, most of the patients on the adult side that you see, their diagnosis has been known for a few years?
That's correct. There's a group of patients with chronic liver disease ending to end stage. However, there's a subgroup, a very small group where just out of nowhere, Just it can happen to you and me with normal liver function, and then suddenly with either a viral infection or just a bad reaction to an antibiotic or any drugs, Tylenol, that they eventually go to acute liver failure, and then that also is considered end stage, because without a transplant in an urgent manner, they're not expected to survive.
Sure. And so on the adult side, most of the patients come fairly well known and advertised. On the pediatric side, the babies that you operate, those are usually fairly emergent situations, oftentimes within the first couple years of life. Is that correct?
That's correct, yeah. Because the most common time where it occurs on biliary atresia that you require transplant would be, in the first few years of life.
Yeah, and I know that you've a number of your patients have been written up in the local newspaper, have been on TV, because they have been truly heroic and life-saving procedures, especially with some of the live donor operations, and we'll talk about that in a second. But the majority of patients who receive a new liver receive that liver from a recipient who has been in a car accident or some traumatic event that has resulted in an irreversible brain injury. Is that, maybe you can talk a little bit about where the organs come from for the patients that you replace.
So nationally, and same as our program, approximately 95 to 97% of the livers that we use in this country are from deceased donor. And of the deceased donor, they could either be, brain dead, or if they don't meet the brain dead criteria, they could donate after their heart stopped beating. So either one of the category would declare them as eligible to donate.
Sure, and I know that you, with the babies that you operate on that have liver transplantation, oftentimes a family member will donate part of their liver for the babies, correct?
That's correct, yeah. So the challenging things for a small child or babies are that there's not enough small whole organ donors. And so we either use a parent or a family member who wants to donate a piece of their liver, or in the case of brain dead donor, we could split the organs into two, and hence we're able to save 2 lives out of 1 person who died and donated the liver.
Sure, well, fascinating. I know that when you came here in 2012, I know you spent a huge amount of time developing your team, and I think it's very hard for someone who hasn't witnessed this to appreciate the tremendous effort involved in a liver transplant program. Everything from the transplant coordinators to the social workers to the psychologists to your entire operative team, which is a small army of dedicated anesthesiologists, scrub nurses, circulating nurses, and then here at Frederick Hospital, you also have developed a dedicated intensive care unit just for the liver transplant patients. But maybe you can talk a little bit about how just globally how a liver is taken out and replaced, and the importance of working with the same people all the time.
Yeah, first, I think I'm really fortunate to be here, and second, I think everything comes from the top, wherein, as you mentioned, to have this infrastructure and the number of resource and the amount of resource necessary has to come from a commitment from the top, from the department, and most of the liver programs are developed through Department of Surgery, and because the reason for that is because the surgeons are typically involved in all the phases of care of the patient, and including from the organ procurement and training of the operating room and care of the patient. So why we have to have a comprehensive or very consolidated integrated program is that a lot of things are happening at the same time, and so you would have to be able to dispatch 2 A teams out. 1 A team goes and evaluate the organ.
So the donor may frequently be a plane ride away.
Correct.
So you have obviously a number of surgeons that work in your unit, and so 1 or 2 surgeons would then get on a plane to evaluate the organ in Montana,
Hawaii,
or it could be almost anywhere, right?
Yeah, almost anywhere. And then while they're evaluating that, they have to make a decision whether, 1, if this is the right quality of organ? 2, are we able to split this and save 2 lives out of one single organ? As you know, there is a severe shortage of organs. And then not only make that decision, but preserve it, procure it, and preserve it in the best possible way. On the other hand, we're here. We have the second A team here preparing our patient. Now, this is a collaborative effort with our intensivists, with our anesthesiologists, our hepatologists, and our advanced practitioner, which includes the nurse practitioner, PA, coordinators, ICU nurses, OR team. We're preparing the patient to optimize him in the possible way to undergo one of the biggest operations that we could do.
Because obviously there's a list of donors, and that list is prioritized based upon how sick the patient is.
That's correct.
So oftentimes your patient is in the intensive care unit. The potential recipient who's going to get the new organ, oftentimes on a breathing machine, sometimes relatively quite ill.
Correct.
Right?
They're on breathing machine. They need the 24-hour hemodialysis. There are some drugs. And just because it's a federal mandate to allocate, as I mentioned, there's no option for a patient to bridge them over. So the allocation of liver mandated by the federal government is it goes to the sickest individual. And so most of the transplant in liver are happening or occurring in very ill patients.
Wow. And maybe you can talk a little bit, just in general terms, you have the recipient who goes into the operating room, and oftentimes you'll start the operation once you get a phone call, right, from your colleagues who are satisfied with the quality of the donor liver. And then while they're traveling back to Milwaukee, you'll start the operation here?
Yes, correct. So one thing that we learned throughout the years is that in order for the patients to benefit from transplant, to have them the best chance of survival, you determine what are their comorbidities. Obviously, we know they're sick. What are the things we can do to improve their medical condition to survive not only through the transplant, but after the transplant? Second is what is the quality of the organ? And also, what are the operative factors? So one of the operative factors we know that would improve the function of the new liver is the shortest possible time that the organ is outside the human body. Sure. So in order for us to achieve that on a very ill patients, we have to really shorten or minimize the time that's outside. So all this coordinations happening while once we have a confirmation it's the right organ for our patient, then the second A team in-house here start working on our patient so that when the organ arrives here, the patient's own liver is ready to come out, and then we're ready to sew in the new liver.
Wow. And when you sew in the new liver, maybe you can talk a little bit about how many blood vessels you have to hook up along with the bile duct. Just basically, I think many people will have access to, they'll just Google the anatomy, many of the viewers of this video, so they'll see roughly what the anatomy is, but maybe you can talk about the order of how you do it. And since I've watched you do this 1,000 times now, I know that you sew it with a needle driver and thread, but it's fascinating to hear you talk about it.
It's probably one of the most humbling procedure I've done. And the human body is just amazing. So pretty much doing a liver transplant, you're disconnecting the blood flow of the lower body from the upper body as the liver is in the central portion. So as we remove the entire liver, the blood flow, the major blood flows are disconnected, which is the vena cava. So there are 4 vascular anastomosis. And the first one we sew in is to the vena cava near the heart, which is what we call the suprahepatic vena cava. And then the second anastomosis is the vena cava near the kidney veins, which is the infrahepatic vena cava. And then the last 2 anastomoses are the blood supply of the liver, which includes the portal vein and the hepatic artery. And then after that, then we still have to reconnect the bile duct, either using the recipient's own duct if it's usable. Sure. In some cases it's not usable, then we have to reroute his or her intestine, what we call Roux-en-Y hepaticojejunosty.
Yeah. And depending on how sick the patient is, what's the spectrum of how long they would be in the hospital after a liver transplant?
So obviously for as long as they were sick, so the sicker they are, the longer they need to be in the hospital. While the organs have recovered after transplant, Physically, they still are pretty much deconditioned, malnourished, so they stay in our hospital from the ICU to the ward. We work with our nutritionists, with our physical therapists, with our coordinators, and our APPs, our nurses, and get them through of several weeks of rehabilitation. And then if they still require, then they either go to a rehab place or sent home with home physical therapy and nutritional support.
I know that all the patients are put on some form of immune suppression because it's not their own liver. It's even though you try to match everything as best you possibly can with all of the typical matching systems that are used. What is the chance, though, that a patient in the first couple weeks after a transplant will not accept the organ and will reject the organ? Their immune system will reject it.
So there are two issues that we look at in the first week of transplant. The acute or hyperacute rejection, wherein the body completely rejects it and then the liver fail, is quite rare for liver. It can happen in other organs, but with the current medication, it's quite rare. Although there is one entity, which we call primary non-function. So that's not related to rejection, but typically the liver just won't work, no matter how perfect the match is, how perfect the operation went, and no matter how short that cold ischemia or the organ preservation time. That occurs in about 5 to 8%, wherein the primary non-function of the liver occurs. If that happens, then the patient would require an urgent retransplant within the next few days, or they will not make it.
Sure.
And so the risk of that primary non-function is higher for a sicker individual, for organs that are preserved longer, and so that's why it's so important to have the team effort that you mentioned to work, for the best interest of our patients.
So assuming that the recovery goes okay, the operation and the recovery goes okay, there's no evidence that the liver isn't working, it's working well. And assuming the patient takes care of themselves, what's the likelihood that they will be well 3 and 5 years after the transplant? Because I think many people now, with the availability of liver transplantation, it would be common that many people viewing this video will actually know someone who's had a liver transplant.
So we follow the data, most of the national data up to 5 years. So after all comers in the adult population, the 5-year survival is about 65% to 70%.
Wow.
Now, a lot of patients live beyond 20, 30 years or so. And also that's going to be good for the rest of their life.
Sure.
Yeah. Knowing that before the development of transplantation, this patient would not even make it up to 1 year. To have a 70% 5-year, I think it's an excellent achievement.
And in the small infants that you operate on, say within the first, I forget exactly how you classify them, but I think you have a classification within the first 2 or 3 years or something, or by weight.
Yeah.
What is their long-term outcome?
So the kids do better. So their 5 years, about 80% or so. And we have kids who live a normal life, got married, have children. And so I think one of many may not know that one of the goals of transplantation is not only to prolong their life, but to really improve the quality of life, to live a near normal or normal life, having family and achieving their own personal goals.
Wow. Well, Johnny, thanks so much. This has been fantastic. And I think I know many people, if they Google you, will find some of the recent newspaper articles about you, your team, most importantly, your patients. But it would also be fantastic. I know that you oftentimes speak to lay audiences, and I would encourage all of our viewers to look up Dr. Hong on whatever media you would like. Certainly there will be information to follow at the end of this video. I think the work that he is doing is absolutely fantastic. And thanks, Johnny, for taking a few minutes.
Thanks, my pleasure. Thank you.
Yeah.